we've heard a lot about how precision health actually provides better opportunities for what we've been doing traditionally, but with the intent of targeting the interventions, the efforts, be it in health promotion, disease prevention, or even on the delivery of primary and tertiary care services in a better way, such that the people who needs it most at the right time will be able to achieve that. So this concept about equity, it's very similar to traditional public health issues. Dr. Margaret Chan talked about effectiveness and sustainability, because it's very important to always remember that just because an innovation exists, it doesn't mean that it will definitely be effective or even cost effective to be sustained and to be scaled up. And what we've also seen as part of COVID-19 and in many other aspects of public health is that just because an innovation that is cost effective in one country setting may not necessarily translate to the same when we move to another country setting, especially for precision-based approaches. Because we've heard a lot about how Andrew talked about this requires substantial development and investment in infrastructure, in informatics, and more importantly, in the human resource for a country. So when we come back to this issue about equity, this is really where precision methods both have the opportunity to bridge and improve equity or dangerously widen the crack of inequity, because resource-rich countries are able to execute and deliver on some innovation ideas much better, whereas resource-poor countries will really struggle to really even adopt some of these innovations for a small group in the country. So what has happened in reality is that a number of low and middle income countries have depended on official development assistance, or ODAs, to deliver precision-based approaches. For example, the use of gene experts for TB diagnosis, for rapid identification of drug-resistant TB in different parts of the world, or when we think about genomic surveillance of malaria outbreaks to rapidly identify the emergence of drug resistance in parts of the Mekong Basin in Southeast Asia, or even the use of mobile technology to rapidly identify the need and to deliver postnatal care in rural parts of India, which I believe will be the focus on the subsequent sessions on LMICs. But importantly, while such ODAs have been vital to allow many of these LMICs to adopt new technologies, fundamentally, the health systems of these countries have to evolve to a level where these innovations are very much part and parcel of their healthcare delivery. Otherwise, reality is that many LMICs simply will not have the ability to adopt these approaches without compromising on the budget for other parts of national development. The reliance on ODAs, on development assistance funding, becomes even more problematic with some degree of ODA transitioning. And this is when countries suddenly see a drop in development aid funding when a country transits between their status, say from low income to lower middle income. And some countries actually, as part of this transitioning, will no longer be eligible to receive some of the support funding. So ironically, this can result in a decrease in the ability to deliver better health innovations to the people. So this is really the reason why many speakers have highlighted the problem of equity when we start to think about the use of such technologies. So David, you asked me the question on who should pay. Really, for a sustainable approach, it has to be measured in the local country context in terms of the effectiveness and also in terms of whether it is sustainable in the long term for a country to adopt some of these approaches, regardless of whether there is or there isn't ODA, because otherwise the ODA transitioning can result in a lot of inequity cracks that will subsequently be introduced.
I'm the principal investigator of GenRe Mekong, which is a large-scale project that conducts genetic surveillance of malaria parasites. And thanks to YY for giving us a shout out in the earlier session. We are funded by the Bill and Melinda Gates Foundation, and we work with malaria control programs in the Ministry of Health of the various GMS countries, with the goal of informing their decision-making and basically optimize the path towards malaria elimination. Malaria is, you can think of it as the archetypal low and middle income country disease. It mostly kills children in African countries. And by comparison, in Southeast Asia, we have much lower mortality. But paradoxically, the interventions in Southeast Asia have great impact worldwide, including on those children in Africa, potentially. And this is because Southeast Asia, over time, has been repeatedly the epicenter of the emergence of drug resistance to antimalarials. And we've lost major drugs like chloroquine and sulfadoxine, pyrimethamine, and so on in the past. And right now, there's very much an ongoing threat that this is going to happen again with artemisinins, which are the main frontline drug. And if this spreads outside of Asia, it could roll back the great progress that has been made in the last few years. So, in the earlier presentation, there was the great quote that we have the tools to provide the right interventions to the right people in the right places. And in the GMS for malaria, the right intervention means that national malaria control programs must use effective drugs that will prevent the spread of resistance to the rest of the world. This might seem a very basic application of PPH, but in fact, the reality in low-income countries is that a lot of the basic information flows are just simply not there at the moment. So right now, the control programs don't have very efficient ways of knowing about resistant strains and whether they're spreading. In the last 5 years, we have seen a dramatic example of this, with a strain of parasites resistant to both artemisinin and piperacin emerging in Cambodia, and because all the neighboring countries, bar Laos, had adopted exactly those two drugs as the frontline therapy, there was a very rapid and incredibly penetrative spread of these drug-resistant strains across borders. So, so the question is, can we give control programs the right tools? So our project collects blood samples from the health centers in the remote endemic areas of these countries, which are actually sort of hard to access. And we use genomic technologies, high throughput, in order to detect basically a whole panel of drug resistance mutations and then report their prevalence to the control programs. Now, we have now done this in all of the countries in the GMS, and we've processed about 15,000 samples already. And this is continuing in some countries, in most countries, actually. We are now doing this routinely and have incorporated this process in routine malaria treatment. Now, what I wanted to highlight is that in order to do this, we really had to make the process simple enough. And I don't think this can be stressed enough. In these settings, technology is very limited. And I'm not talking about having a sequencer on site, and I'm not talking even about mobile phones. I'm talking about whether there is even a refrigerator to keep a blood sample in. So it was very important for us to be able to sequence from a dried blood spot that could be kept for a month at a site inside a little plastic bag with some silica gel. And then we had to simplify metadata collection so that it would require minimal training to get the samples. And then we had to bridge the knowledge gap to the control programs such that we would employ sort of fairly simple and somewhat blunt visual instruments in order to convey the messages back, because basically public health officials in these countries don't have a background in genetics. So ultimately, it's very much about simplifying so that you can integrate. And actually, we've had some success stories. The Lao authorities, for instance, did not switch to DHA piperacin as a frontline precisely because we showed them that these parasites were coming over the border and it would be unwise. And in Vietnam, some provinces where we work were reclassified because they didn't know they had resistant to artemisinin in there, and we revised that. And so this is something we are able to achieve because basically genetic surveillance gives us results fast, much faster than basically clinical efficacy studies and so on. But of course, even once these countries have these data available, there is still very onerous for them to change policies. So this is another issue that low-income countries are facing. And just to complete the picture, moving forward, what we are hoping is that the same processes of sequencing can also give us information that, for example, will tell us about importation of samples, that will tell us about the nature of outbreaks, and so on. So we hope to be able to extend this to give a more complete picture to the control programs. Thank you.
To me, one of the great lessons is that preparing is much more than having a plan. Preparing means having in place the prior understandings, the prior commitments, the prior agreements about ways of proceeding that reflect the point that Margaret was just emphasizing, a global commitment of mutual responsibility, of accountability, of a sense that we are in a struggle in the world as one world.